All right. All right. Well, good morning, good afternoon, depending on where you are, and maybe good evening for some of you as well. My name is Adimika Arthur. I run a nonprofit called Health Tech for Medicaid, and we are here today to talk a little bit about designing for dignity and how we will disrupt the workforce. I think many people understand, and you can move to the next slide. So Health Tech for Medicaid, we're a nonprofit organization. We've been around 4 years. We'll be celebrating our 5th year this year. We are dedicated to supporting innovation in Medicaid. Just a refresher for folks, Medicaid is the largest insured population in the country. And our purpose is to further improve quality, equity, and access to care for Medicaid recipients. For those just joining us, we love to be interactive, so you're certainly welcome to introduce yourself. Part of the reason why we do this is a meeting and not a webinar is so that you can feel like you can get your questions answered, meet people across the Ethernet. And we are best known as a convener in this ecosystem to bringing people together. And so it's a little odd to be doing this all by Zoom, but I know it's made things much more convenient. And certainly in this case, we've got experts from all around the country, and we're really excited. So Design for Dignity is a series we started really last year seriously, but these principles of equitable and inclusive design is part of the reason why we exist as an organization. Equitable and inclusive design is really a thought process in design on how we can eliminate exclusionary barriers in either the way we describe it at Health Tech for Medicaid is we like to disrupt products, services, delivery systems, capital markets, and a bit of narrative change, right? And so we do that with community in mind, but we actually do it with community, right? Not for community, which is a bit different. The Medicaid population is deeply underlooked and often not thought about at all in the design ecosystem. And we've worked with worldwide leaders like, Deloitte, IDEO, many others, and Cope Health Solutions, who we're working with here today, has been doing this work in communities through a consulting lens for quite some time. So we're really excited to talk about how do we think about completely redesigning the workforce. And we'll also really have a national leader today kind of tell us why we may need to consider that. But ultimately, our goal here is to really confront bias and to really keep very good inclusion and exclusion criteria together so that we can actually design better with our communities. And more of and human-centered design has been a topic which we've talked about, but it's really people-centered work. So I don't need to frame the state of the healthcare workforce because Jeff is going to explain a lot of it. I just want to say in this call, we're going to be encompassing of more than just the care delivery system. Certainly thinking about the public health workforce, which, I personally am an epidemiologist, have spent my career both anchoring the beginning of my career in local public health departments, as well as in public hospitals, a little bit of a rare career trajectory in that sense. But I would say that we're not going to just talk about the healthcare ecosystem, that there are many anchoring components that impact health for sure. And that includes, products and companies, et cetera. Next slide. Well, I'm thrilled to kick it off to a longtime colleague and friend. And I will say that I've known Jeff and watched Jeff from the very early part of my time in California as an epidemiologist at a public health department, shockingly enough. That was well over 20 years ago. And Jeff has been a force, not only in pipeline development for students to think about careers often not traditionally just in medicine, but in public health. He has deeply been a part of the academic infrastructure and really shaping and developing many young people's lives who are now wielding big boardrooms and incredible C-level jobs across the landscape. But I really want to formally kind of introduce Jeff and have him introduce you, and then he's going to frame our discussion today before we get to our panel.
Well, thank you, Adimika, and thank you for the opportunity to be here today to speak with you all about this really critical topic. I'm Jeff Oxendine. I'm the CEO of Health Career Connection, which I'll be sharing a little bit about. Also spent many years at UC Berkeley and the department in the School of Public Health, and I'm co-director of the California Health Professions Consortium, which is a statewide coalition to build a more diverse health workforce in California. And I was recently the co-director of the California Future Health Workforce Commission that I'll be sharing about. The next slide, please. I'm going to give you an overview of what are some of the health workforce challenges that are emerging now, and then what are some of the solutions and frameworks that we can pursue, and talk about briefly about Health Career Connection as one possible solution. Next slide. So guys, I have to thank our health workforce because we really are having a deep debt of gratitude for how the health workforce and public health and mental health, all of our health workforce has stepped up during this extended pandemic. We all owe them a great debt of gratitude. The next slide, though, talks about the impact of this work that they all did to step up. Before the pandemic, we already had significant health workforce shortages in many areas like primary care and behavioral health and public health, and some of the other, some of the technical professions, somewhat in health IT. We had a maldistribution where the workforce was not where the need was. We already had an aging workforce and inadequate diversity. We already had a lot of burnout prior to the pandemic, and we had a lot of barriers to being able to get enough people into the workforce. Many of us started working on this back in the early 2000s to sort of ring the alarm that we were going to have major workforce challenges, and many things began to get put in place, but I think not enough and not quickly enough to prevent the crisis that we're going in now because of the pandemic. We do have more issues of safety of the workforce and safety of the patients that we're providing services to. The workforce is tired. It's like running a marathon and more. And so we have a lot of burnout, a lot of mental health issues for the health workforce. And we had the shortages that we had before are still significant, but we have some new ones that have really worsened, like the registered nurses shortage I'll be speaking about. And then we have, as a result of the shortages, we have increased labor costs, and that is resulting in higher costs and declining margins for our health organizations and providers, which is putting this even more in a more challenging situation. And a lot of the people that are still in the field are barely hanging on. People are going to be retiring. People are planning to leave the field. Fortunately, we have some disruption with the use of telehealth, and other kinds of remote and digital solutions, which were really forced by the pandemic. If there was a silver lining, we went more quickly in those directions. But now we've got some real problems in the pipeline for clinical training and placement and faculty and those kind of things. And we've still got more health inequities as a result of the pandemic. So it's a very challenging situation that we find ourselves in, which is why it's great that we're having this conversation, and we've got a lot of action and investment taking place as well. Next slide, please. So there was an article recently about the number one thing keeping hospital CEOs up at night. And for the second straight year, health workforce challenges were the number one concern. This was from an ACHE survey. No surprise that nurses were the highest concern that people had. Prior to the pandemic, there was nursing issues in some of the areas, but now we've got nursing challenges all over. There are also some other technical staff shortages and just burnout among staff as well. So on the hospital side of things, huge workforce challenges that need to be addressed at a challenging time. Next slide, please. From the standpoint of the California Future Health Workforce Commission, which I co-directed, we had the top leaders in California come together and say, and this is just prior to the pandemic, what do we need to build a future workforce by 2030 to advance equity and to provide the right level of disrupted upstream health for people in California, as well as healthcare access. And in that case, the commission focused on three primary focus areas: on primary care and prevention, which included public health and other aspects of prevention; on behavioral health, mental health, and substance use, because we all know that we had, prior to the pandemic, we had significant challenges. 90% of the people in the country now feel like we have a mental health crisis on our hands. And so that's even worsened. And then as the population is getting older, having enough people to take care of us all, to take care of us in our homes, to take care of us digitally, to take care of us when we need hospice and other kinds of long-term illness care. So we, our commission focused on, for California, these three kind of overlapping areas. And this is something that I found in my work around the country are also three of the most highest priority areas. And then obviously increasing diversity and equity across those areas, and then leveraging technology as solutions, because we're not going to be able to produce enough people in the time that we need, in the places that we need them, nor could we afford it if we could. And so definitely leveraging technology as disrupting the way that we do things going forward. Next slide, please. In addition to these areas, we need to work on the diversity of the populations. This slide's a little bit old now, but the ratios are still the same. I saw some recent data from in California that now, whereas the population of California is 38% Latinx, now 10% of the physicians are, instead of 7% here, are from Latino backgrounds. And so we need to, I think we all know we need to increase the diversity of the population, I mean, of the workforce as well. Next slide, please. Adimika mentioned the public health workforce, that we've now all seen the critical importance of having the public health workforce that we need. The DuBois Foundation, so I'm co-chairing their National Public Health Workforce Retention and Recruitment Work Group, has been doing some great research on what do we need to even meet our basic public health need. And they've come up with 80,000 additional public health workers that we're going to need just to meet our basic public health needs, not necessarily all the health inequity kind of work that needs to be done. And that's a challenge when a lot of people that are in the public health workforce, when we need that additional 80,000, we got 44% that are thinking of leaving in the next 5 years. We also don't have the diversity there that we're looking for, particularly at the executive level. And the workforce is suffering from PTSD. The good news here is that there's billions of dollars invested at the federal level that's trickling down to the states and the counties to try to build a more public health workforce, a robust, diverse public health workforce. We've got to make sure it's implemented in the right way and achieves the intended results. And this National Public Health Consortium I'm working with is working on 3 major areas, really clearly defining the needs, making sure we're recruiting the right people, and being able to change that in terms of disruption, really being able to change the hiring practices and many of the other barriers to getting a public health workforce that we need. Next slide, please. We also need to have more diversity in leadership roles. We partner with the National Association of Latino Health Executives, which has identified that we need to have diversity of clinicians, but only 3% of the hospital and C-suite leadership are Latino, when 38% of the California population is, probably 25% in the country, and only 9% are identify as minorities. And so when we're doing our work, we've got to also make sure that we're not only getting the frontline workforce and the public health workforce, but getting people into leadership roles as well. Next slide, please. And then, so how do we do this? How do we actually put things into practice and solve these issues? It is possible. For the California Future Health Workforce Commission, we came up with 3 overlapping strategies. The first was to increase opportunity for all people to become health professionals in California, including scaling pipeline programs and supporting more college students to get into health careers, providing more scholarship support. We've made really good progress. The state has invested, and philanthropy's invested, in that area, but you can't get people into the process, into the pipeline, unless you have enough capacity to educate them and provide them with the right skills and training. And so we also have had to expand the residencies and loan repayment and educational capacity in medical school, and getting more rural opportunities for people to get into the workforce. And then the third is we've got to have the capacity, strengthen the capacity and the well-being of the current workforce that we have and how they're most utilized. So better, maximally using nurse practitioners to the top of their scope, for example, and training nurse practitioners and primary care doctors on behavioral health in a way, because we're not going to have enough behavioral health professionals. Using more community health workers and peer support specialists and promotoras and others to be out there doing prevention work and to help people navigate the system. So these are some of the solutions that are actively being invested in and are making some progress. Next slide, please. I know Health Tech for Medicaid, focus on Medicaid. These are from the Kaiser Family Foundation, focusing on what are the strategies to address behavioral health workforce shortages And you can see it involves a combination of things, increasing rates, which we all know is needed for people to go into the field, as well as incentivizing their participation, having more extenders in the workforce and reducing the administrative burden. So these are things that we need to disrupt if we're really going to build that workforce that we need. The next slide, please. If you could just build this one all the way out, this is just one of my models around the coordinated future health workforce pathway. If you can just click, I don't know maybe it's not built. There you go. Build it all the way out. This just shows that you have to have a systematic approach to this. You can't just say, because a lot of people say, oh, let's just go increase career awareness, or let's increase loan repayment, or let's increase residencies. We have to have a coordinated approach so that all the way from all different target groups, and we have to look at new groups of people to become part of the workforce. We've got to have a coordinated way that we help them with career awareness through health professions training, being able to afford it, to have internships and residencies, to get hired, to be onboarded, to be retained and advanced in cultures that promote equity and diversity and are inclusive with people, to get them to stay and to pay them well enough and to help them get hired. So this is just advocating that we do this in a systematic, coordinated way. The next slide shows that we need to do this at the regional level. A lot of this has to take place at the national level, the state level to invest, but also at the regional level. It's important to, the rubber meets the road at the regional level. So that we need more things like this is from One Future Coachella Valley, which is growing their own workforce. They're out in the desert in California. They don't have other places to draw people from. So you can see they're working from elementary school to high school through college and into the skilled workforce. And they've identified what their needs are, and they've got businesses, they've got the workforce boards, they've got the universities, they've got K through 12, everybody pulling together in that coordinated way that I showed you to build that future workforce. So we need to have more investment in these regional collaboratives to build a health workforce. Next slide, please. And then we have to have a coordinating at the statewide level as well. There needs to be accountability for all this money that's being invested to make sure it's meeting the intended results. There need to be updated plans and data showing how we're moving the needle. We need to align the regional efforts with what's happening at the statewide level and also at the national level as well. But there has to be accountability. No one has owned health workforce before, so we need to make sure that there's ownership at the statewide and regional level for making these things happen. Next slide, please. And then just finally for Health Career Connection, because I only have a couple minutes left here, a very practical, proven, immediate thing you could do is Health Career Connections, a national nonprofit that I run, that we work with talented undergraduate students and recent graduates from local communities to be able to get paid internships and jobs and get into the health workforce to become leaders. We've got 4,600 people who are doing that already, as Adimika mentioned, who are in C-suite kind of roles. They're providers, they're in public health and behavioral health, number of kinds of things. So you can partner with Health Career Connection. We're a national organization. Next slide, please. And we have students from communities of color and all throughout the country who get jobs, they get into graduate school, they become this future workforce, and then we can hire our alumni as well. Next slide, please. And we just do this through a comprehensive framework of experience, mentorship, community building, and professional development. Next slide. Just to show you the benefit. So all these kind of things, the regional initiatives, the investment in the behavioral health workforce, Health Career Connection, can result in people like Dr. Evita Limon Rocha, who's from the local community, the Inland Empire, the most under-resourced community in California in terms of health workforce. She's a child and adolescent psychiatrist, a unicorn, basically. You can't find people like that very often. She's from the local community, speaks the language. She's also an advocate for policy change. The next slide shows some other Health Career Connection alums. But the person on the right there, Brittany Giles Cantrell, is the head of now health workforce for the DuBois Foundation and health equity there, advancing public health workforce initiatives. So it's possible, they're out there, and public health workforce and health workforce development is a win-win for everybody. We get the workforce we need, the organizations get workforce at the cost that they need, meet their needs. We end up empowering local people from our communities who reflect the population to be successful, and we have better health for all. So those are my comments about the state of the health workforce and some immediate solutions. So happy to work with you going forward if I can in any way possible. So with that, I'll turn it back to Adimika.
Thanks so much, Jeff. That was really helpful. And I think a really great layer of groundwork for our panel today. So I'm going to go ahead and start our panel right now just due to time. And I'm really excited about the breadth and depth of diversity that we have on this panel today. I'm going to have each panelist introduce themselves, and as they introduce themselves, really talk about one question, which really has to do with what are you seeing right now as we move into this workforce as a major challenge in your market. So if you were to say the main challenge that you're seeing on your desk, what's keeping you up at night, kind of similar to what Jeff asked California leaders across the country, or what Becker has asked hospital leaders across this country. Introduce yourself, tell us who you are, what you do, what you're passionate about, but more importantly, tell us a little bit about what's keeping you up at night as it pertains to workforce. Go ahead and start, Elizabeth.
Sounds good. Thank you. It's a pleasure to be with all of you today. My name is Elizabeth DuBois. I am a doctorally prepared family nurse practitioner. I still practice, but my main role is as a principal and chief operating officer for Cope Health Solutions, which is a national healthcare consulting firm with an arm in workforce for the last 22 years. It's the bread and butter in how we built this company. And so, I've done multiple workforce programs throughout the years. And I think the main point I probably would stress right now, and I talk to the healthcare systems about and the payers, is we cannot rely on academia to produce the needs of the workforce for what we need right now and what we're going to need in the future. And we, as healthcare organizations, healthcare systems, payers, have to think outside of the box to build our own models to augment or supplement academia in order to really have the workforce that we need, whether it's in diversity, whether it's in the competencies and skills needed, whether it's in the actual numbers of people. And so I think that is kind of the main point I'm trying to stress across the country right now.
Wonderful. Ben, we're going to kick it off to you next.
Sure. So Ben Kornitzer, I'm Chief Medical Officer for Agilon Health. I'm a primary care physician. I specialize in the care of high-risk, homebound older adults. Agilon is an organization that partners with primary care physicians around the country. We're in 12 states. We've gone at essentially full risk for the lives of 500,000 seniors through our country. And so, what I'm very passionate about is value-based care and the care of older adults. What keeps me up at night, other than a 2-year-old son, is every single one of our physician markets. Again, this is 25 markets, 12 states, is deeply concerned about retaining their primary care workforce, particularly in underserved, either urban or rural communities. These are, at risk of becoming primary care deserts, and really, really hard to reestablish that community-based primary care once you've lost it. And so thinking creatively outside the box, whether it's partnerships with groups like COPE to launch APP fellowships, whether it's completely redesigning how we incentivize our physicians so that they can use their workforce differently, leverage technology, just really, taking whatever we have right now and transitioning it all to value. And look forward to sort of, talking about some more topics, perhaps, later on, I think, in terms of health equity, in terms of, closing some of the wage gaps that we're seeing among the workforce too. Value presents a really compelling proof point.
Wonderful. And last but certainly not least, the person who's literally sitting in the hot seat and doing this work every day, Jen, introduce yourself.
Thank you, Adimika. Can you hear me? I was having problems with my mic. Okay, perfect.
Loud and clear.
Thank you for having me today. My name is Jennifer Diehl. I am the HR executive for talent acquisition and workforce development at Adventist Health. We have 23 hospitals, just under 400 clinics along the coast of west coast of California, from Oregon all throughout California and Hawaii. So yes, we have a very busy docket. We fill about 12,000 positions a year, and we fill about a little over 2,000 nursing positions a year, and it'll never be enough. So when you ask about what keeps me up at night, 100% very easy answer by a landslide is our bedside nurses and the shortage that we're having to deal with year over year, continuously lobbying our wonderful state of California and our Board of Registered Nursing to expand access to these programs, please allow us to join the compact states. There are 40 states in the country that are part of the compact state pact. California, Hawaii, and Oregon are not. So it makes it very difficult to, relocate nurses from across the country, to get international nurses in, trying to get as creative as possible, not only, redirecting market share of existing, qualified and experienced nurses, but from the BRN perspective related to access. I was just on the call with a California BRN 2 days ago, lobbying in support for an educational institution to expand their enrollment. In California, if a nursing program wants to increase their enrollment, they have to have the permission of the BRN. There were 12 schools that applied on the agenda, only 2 were approved. So it's been a very difficult road for us trying to work with our public agencies, not only to increase the entry-level pipeline of creating more nurses with a 45,000 nursing shortage in California, but also trying to get creative around redirecting some of that market share from across the country, relocating to California, and so forth. So it's kind of, all right, we're a little handcuffed over here on the West Coast, and so we have to get as creative as possible. So that's what is definitely keeping me up at night.
All right. So I mentioned in the beginning, talking about who Health Tech for Medicaid is and kind of who we work with. We are a convening body, so we kind of bring everyone together. And I think that's shown today in the diversity of kind of what we've put together. But I'd love to know, at least vulnerable populations, those are the folks I think about the most, the 87.5 million people on Medicaid. But I was a hospital leader for a very long time. I ran hospitals, Jen, so I understand your pain, and Elizabeth and Ben, I'm an epidemiologist, so kind of understand your pain as well. On the demand side, I wonder what special populations you tend to focus on the most, and what strategies are you seeing that are novel, that is working? Elizabeth, maybe we can kick off with you.
Sure. I mean, I kind of look at that question twofold. I look at how are we training the workforce to care for the populations, and what populations are we concentrating on to bring into the workforce? And so I think, when I split it into that section, for what are we concentrating on to bring into the workforce? And I think Jeff highlighted some of this stuff. We have these huge workforce gaps, but our current academia models, and I don't mean to, I'm not going to offend anything within academia or anyone, but our current models are not conducive to bringing in a diverse workforce, and individuals that want to get into healthcare. And so when you look at, let's say, medical assistant schools, the majority of them are 12-month programs. They're 9 to 5. They're full-time. Some of them cost $30,000. So how many individuals from the community are going to be able to apply to this program and not be able to work, not be able to care for their family, take out student loans for the program, and then have close to a minimum wage job? We desperately need more medical assistants, but our current structure is not set up for that. You look at the nursing schools, there is a huge shortage of spots to accept nursing students. Yet on the other side, we have this huge gap. And so, that's where I think I look at how are we bringing in these populations that want to be in healthcare, but don't have the typical access or ability. Maybe they don't have a family member that's a nurse or a doctor, and so they don't know what they need to do, or they don't know, they're not sure about how to write their application essays or make sure they have a real chance of getting in. And so when I think about that, that's where I think is our opportunity as healthcare systems to think outside the box. And so, one of the things that we did is we created our own medical assistant program, and we partnered with Jen and Adventist, and we said, we're going to do a program that is majority asynchronous, so they can still work during the program. They can still care for their family members. We're going to do a program that is little to no tuition, and so they don't have to worry about that. And then they can, go in and be BMAs. And our first cohort, we started in a very rural part of California, and we got applicants, that We had a single mom of 6 children. We had an individual that had worked night shift as a EVS worker, always wanted to get into nursing, but had never had an opportunity before. And so, creating these type of programs, whether it's for medical assistants or, sometimes we get a little bit more structured MAs and surgical techs and radiology techs, there's a lot more room to do these kind of programs at the entry level. Sometimes when you're starting to talk about the RN or the APP or obviously the physician, you get a little bit more restricted in what you can do. But then you look at, okay, what can I do on that other side? And so if I'm thinking that some individuals may not be going to programs that are necessarily preparing them well to practice or be successful in practice, what can we do post-grad to transition them in and be successful and be able to, be resilient and avoid burnout? And then when I think about the special population side and how are we training individuals, I've started practicing in New York City and primary care and FQHCs. I had never had any specific training around the LGBTQ population. I never had any specific training around the HIV positive population. And I got thrown a panel of 200 HIV positive patients and was told to go care for them. And I was like, this isn't fair to these patients, and this is not going to keep me in primary care. And so what we try to do is create programs where we actually look at, so for example, with Agilon, we look at the claims data of the community that's being served. What are the common diagnoses? Where are they getting referred to? What are the procedures that need to get done? So then we can build training for the workforce that specifically meets the needs of those patients. So they understand the complex care for these senior patients. They understand, what is needed to care for them and manage their chronic illnesses. And so instead of following this structured template that you sometimes see, we customize it to the communities that you're serving. And that's also going to help your workforce be more resilient in practice as well.
Wow, that was a lot to digest there. Ben, you want to try to talk a little bit about, you talked a little bit earlier about you guys concentrate really on older adults. And so can you give us a little bit more depth around what you're seeing that is working as you kind of redesign the system, or even, what pieces of the system need to be redesigned to make it a little bit more palatable for older adults, some of whom are working, some of whom are independent, and some of whom have a significant amount of caregiver load themselves with a spouse who may be ill, but also caregivers or, other individuals kind of involved in their care.
Thank you. And, I begin by just, emphasizing what a privilege it is to take care of older adults, the journey that they're on, right? A 65-year-old, may be very, very healthy and robust, but, by the time they're 70 or 75, they may be in a very, very different part of that journey. And so our ability to really have a meaningful impact is tremendous. I'll tell you, first of all, what's not working. So in our current fee-for-service program, nationally, what we see is doctors do a decent job taking care of patients when they're right in front of them at the moment. But what that requires is that patient, can afford the bus fare to get to the office, doesn't have, dementia, doesn't have other serious medical issues, doesn't suffer from anxiety or other things that make it hard to see that PCP. So, we often pat ourselves on the back and the doctor says, listen, I'm doing a perfectly fine job managing that patient's hypertension right in front of me. But as we talked about, those communities, particularly vulnerable, underserved communities, do really, really poorly. The other challenge that we're seeing is in terms of, how physicians are incentivized, where you actually make your money. If you're trying to run a practice and, as altruistic as people are when they go into primary care, at the end of the day, you still have to keep the lights on. You have to pay for your EMR. You have staff that you need to compensate. And you essentially lose money by taking care of your sickest patients. The way that you run a profit is by seeing commercially insured, healthy patients. That makes absolutely no sense. What we're seeing that is really transformational at Agilon is all of a sudden when you incentivize physicians just based on outcome, all of a sudden those patients who used to fall through the cracks, those ones with really, really bad outcomes, and disproportionately those are patients who either are on Medicaid, they're dually eligible, or they're very vulnerable for other reasons. As I mentioned, they have dementia, they have advanced heart failure, they're, on the verge of dialysis. those patients who are falling through the cracks were where we were really struggling. And so, as one example, we have our physicians spend the most time with those sickest patients. If the patient can't come into the office, we can send someone, whether it's a physician, whether it's an NP, whether it's someone else, we can do it. We're essentially breaking down those silos. In fact, it doesn't even matter in our model if we can bill for those services, right? And so a lot of the hurdles that have been created, let's say by licensure or other issues, sometimes all a patient needs is someone that they can trust to talk to them. And so that's really redefined how we align our healthcare time and resources. And then, I think as Elizabeth had mentioned, so as we're looking at the workforce of the future, it needs to sort of be a range of team members. There are things that MAs can do. There are things that NPs, PAs, physicians can do. And breaking down those silos and working as an integrated team is critical. We also know that the runway, right, if you want to rebuild with physicians, is really, really hard. Residency programs are 3 years long. They take a couple of years to get credentialed, super high cost. So you're probably talking almost a decade before you start, rebuilding that workforce. And just to give some numbers to give a sense of like how acute the workforce issues are in primary care. So we had 30,000 adult primary care physicians leave the field of medicine last year. We're reporting 60+% burnout rates. That was a 15% increase year over year. And about a third of primary care physicians are on the verge of retirement in terms of their age. And so we really have, we can't rebuild the workforce with the same distribution of MDs and NPs. And so one of the things that we're working on with COPE, starting with our practice in Columbus, which is the largest primary care independent practice in the country, is building up a workforce of APPs who are really focused on value. So how do you take care of geriatric patients? How do you manage a panel? What does a home visit look like? How do you have goals of care and end of life conversations with your patients? What sort of things do you need to be aware of in terms of sort of, different cultural sensitivities for how you're delivering care? So all those things that we think are aligned with value, it's really critical to have a very different type of workforce that's taking care of patients. And the last thing that we've seen at Agilon, it's very well documented that there is a significant wage gap between, female providers and male providers. And actually, more female providers leave the field of medicine than their male counterparts. What we actually see within a value construct, their performance is equal or exceeds males. And so there's an opportunity to really close that gender gap. And there's also an opportunity from a health equity standpoint, as you see, underserved communities having more and more providers, closing not only the gap of care for those populations, but also for the providers who are caring for those patients.
Wow. Yeah. I mean, I think you're bringing up a lot of systemic and structural challenges. Elizabeth anchored a lot on, how the design of the system was never rational to begin with. Jen, round us off here a little bit. I mean, you're living this day to day. This is literally interrupting your sleep, unlike Ben's 2-year-old. Tell us a little bit about, what does real-time redesign look like, right? For a system that has to keep its doors open, has to still see patients, is really wrecked and recovering from already having an overly taxed workforce that is tapped, right? It's not just that burnout has been an issue in healthcare for as long as I've been in healthcare, almost 30 years. But then on top of that, we've got an ongoing pandemic. I mean, people are forgetting that COVID isn't over. It's still here on top of a really crappy flu year and, an outbreak this year of RSV, which is a very common virus, but, took over literal supply of antibiotics. So you're living this day to day. How are you redesigning the actual machinery and at the same time planning for, as Ben said, you've almost got to think 15 years ahead and reverse engineer that, but also keep the train on the track and still running. It's a super complicated set of questions, but I think I think it's really your reality. So just give us a glimpse into what that looks like.
Yeah, I'll tell you, before 3 years ago, there was no workforce development section on my title. So, in all honesty, I mean, there were several reasons why
There should have been, right?
There
Like,
should-
I mean, I
and
guess that's the
yes.
question I have.
there should have been, and I'll tell you why, is because not only is it in my best interest as a talent acquisition leader, my goal is to fill positions. That is my goal, to fill all the positions all the time so that we don't have any open positions, no contract labor. But when you have these chronic areas of shortage, in rural areas, in licensed areas, and experienced areas, at some point, actually I know when it was 3 years ago, I said, I'm tired of not being able to find any MAs. Like, I'm getting pressure from my presidents. They're wondering what else can we do? We can't get MAs to relocate for $16 an hour across the country. That's not going to work. So that's when I called Elizabeth and was like, please help me. I want to make my own MAs. I want to make my own, turn my front office, my Rockstar front office, workers, or my EVS, or whoever it is, whoever wants the opportunity, I want to give them the opportunity. And then that way it's a little selfish, but it's also who we are as an organization. We're not just a healthcare company, we're a community partner. So, the more we invest in our community members, then, it's the idea is that it, trickles down to their health benefits. But going back, to answer your other question was, how are we managing? We finally decided, let's dig in. I know what these job descriptions say I need, but what does the state regulation actually say? I actually haven't read it. So what is specifically the requirements for this type of a role, or this certification, or this license? What specifically is included? What tasks and responsibilities are included in that scope? And where can I find overlapping scope in the hierarchy of certification licensure, and where does it start? And so when we think about, the health scholars with Elizabeth and Cope, that's just a great way to expose our community members to the different types of careers available in healthcare. I can't tell you how many times I'll go to a high school or a college and they're like, well, don't you have to be a doctor or nurse to work in a hospital? And clearly we all know that is not the case. You can have, a very fulfilling and easily attainable career outside of the clinical space in a
Plus,
hospital.
every profession is underneath that building. I was when people said, like, you're a hospital leader, I'm like, yeah, I literally run a small city every day.
Exactly.
Like, any job you can imagine is up underneath this building.
Hospitality, retail, everything, food industry, it's all there. So, I mean, that the Cope Health Scholar program really does allow for the exposure. I mean, if you were a high school student living in a small town, how do you even get into the hospital to say, I want to learn? It's impossible. There's no opportunity for that. So the Health Scholar helps us get exposure to our young adults and the kids in the communities that we're serving to say, here are some ideas. Let me give you a taste of what that looks like. What are you interested? Oh, you're interested in MA. Just so happens, I will help you get an MA certification. Not only will I give you the opportunity with the Cope MA program to learn at night so that you can continue to work your Monday through Friday 9-to-5 job and support your family, but I'm going to aggressively pursue public funding or private sector funding so I can scholarship you. And then not only am I going to scholarship you, I'm going to give you a job when you're done. And not only am I going to give you a job, I'm going to give you a promotion the next time you take this board. And then
you're talking about really saving people and keeping them in the community. So
absolutely.
That eliminates the e-migration move out of the ecosystem. It also goes back to something that Ben said that was really important, which is like caring for older adults is a real privilege. It's a real honor, but it requires trust. Not that caring for anybody doesn't require trust, right? But it's a different level of trust, I think, right? And so, Jen, it sounds like a several pronged ecosystem from one, exposure of folks into careers, and Jeff talked about that earlier, two, a deep commitment to one, your facilities and the community surrounding your facilities, three, giving people career laterals and pathways that they didn't even know that were possible, and some attention to funding sources that can help them do that. I'm going to ask the $1 million question that people are pinging me on the back end asking, which is, isn't that expensive to do?
Not necessarily. So we've done 3 cohorts of MAs with COPE, and every single one of them, I was able to get 100% funding from my local workforce investment dollars for incumbent worker learning and community learning. Not only was I able to recover the cost of the organization to host the program, but I was able to scholarship every single student. They didn't have to pay a dime for any of these programs.
And just to add to that, like, if you think outside the box, you can make this work short-term and long-term. And I think, Ben and Jen are both kind of highlighting that with these programs and what we're trying to do. So for example, with the Health Scholar, there's a huge inpatient RN shortage. We cannot get RNs quick enough. We know that. So we will bring all these individuals that are in college and high school, even in some areas, that are interested in healthcare, but they don't know how to get in. We're going to train them to come in and be nursing aides, and they can then support, and we're going to put them through rotations all over the hospital. So they are adding, support to the nurses and the CNAs, but they're also understanding, okay, there is a job for me here. There is a job for me here. Oh, there's this whole marketing team in healthcare that I didn't even know. And then on the side, we're putting our money where our mouth is, and we're saying, we need more bodies. So we are going to sit with you and walk you through how to apply to medical school. We are going to do mock interviews with you. Our first cohort we did in Hawaii, they have a huge problem with, growing their community, Native Hawaiians, into the workforce. We had 12 scholars, 8 of whom got accepted into medical school. Like that was, and these are Native Hawaiians. That is, pretty high numbers for those areas. But we said, okay, we need a longer term pipeline here. So we're going to bring them in to help support the nurses now while we're working behind the scenes with them to apply to medical school. And, then they have this sense of commitment and community to Adventist Health in Hawaii, to this organization that helped them get there. And so they're going to come back, once they've graduated. And we've seen that time and time again. And I think, with Agilon and, some of what Ben was talking about too, we're thinking, okay, what can we do short term? So they're going to help. We know there's a crisis right now. We know we need to expand access right now. We know that these seniors need sometimes an additional follow-up or chronic care visit, or to Ben's point, even a home visit. And so we need individuals in now, but we also know we've got to train them to be long-term and be able to actually stay in this practice and not burn out and, feel confident and competent in their care. And so again, we're thinking short-term and long time, and how are we going to build this out? And I think with all of these programs, it's where, again, I come back to think outside of the box, think outside of your traditional academia, and think about what does your healthcare system need right now? And, how can we facilitate this? How can we build our own program? How can we, build a post-grad program or build an actual school? It's not as hard as you think to build some of these programs. I know, myself, I'm not a genius at all. If I can put it together, I think a lot of people can put it together, but you can't rely on what's going to be given to you. You have to look, to how you can build it within your own healthcare system.
If I could just chime into it, and Elizabeth, let me disagree with you. You are a genius, because I work with you and I know it. So no, what I was going to say is I also think that being very forward-looking means not solving for the healthcare, crises of the day, but sort of trying to understand like what we need in the future. And what I mean by that is, it's not just the amount of hours that people in healthcare are working. It's not purely the dollars that we're devoting to them in salary. It's a sense of meaning. And I think that there's I'll give you one small example. It's nothing to do with our APPs, but many of our programs are focused on getting patients to the right specialist. If you have heart failure, connecting you to the right cardiologist. Oftentimes in practices, it is the lowest paid, least trained staff members who are arranging for those appointments. And so they're not able to communicate with the patient why that cardiology visit is so important. And so we often see across the industry, sometimes only a third of patients actually follow up on those. the other side of the coin is that those people, whether they're MAs or other team members, right, if they don't understand why they're helping to facilitate this referral in the first place, it's just a box they're checking. It's just a list that they have to go through that's completely meaningless. But if they actually understand how important it is to keep Mrs. Smith out of the emergency room and how hard it is for her and that she's got home oxygen and what that means for her and her children, then all of a sudden there's a sense of meaning for what you do. And so I do think one of the things that I enjoy most about the work that we do at Agilon, it's only about outcomes, right? Like if it is not better for the patient at the end of the day, there is nothing in it for us. And so I think that gives a real sense of meaning. And so a lot of the people who are leaving medicine, and whether they're primary care providers, whether they're MAs, whether they're other team members, and listen, some of them are going to take jobs at Starbucks. And they're doing it because it feels just as meaningful to be a barista as it does answering the telephones in a medical practice. Like we need to change that. We need to make the work fulfilling and mission oriented. And I think that's a very important part of, what we're all trying to build together.
I mean, I think this is amazing. I have two pieces. Elizabeth, I'm really glad that you stretched and talked a little bit about the cultural component, because we know that cultural concordance is really important in care, right? People need to go into a place that makes them feel comfortable. People need to go into a place where they see people that look like them. And we have a lot of things that are just completely off balance. They make zero to no sense, right? And there are systemic and structural problems that have been a part of our ecosystem from the very, very beginning. One stat that I throw out to people all the time, because they're like, why did you quit your highly paid job to go and start a nonprofit? It didn't, exactly start out that way, but I couldn't just keep watching massive problems happening and realizing there was actually nobody in the world, in the country doing this work. When 40% of Medicaid looks like me, yet 98% of Medicaid decision makers look different, there is a challenge. When 40% of Medicaid looks like me and 12% of the country is me, there is a challenge, and that's insured folks, right? So I do want to speak to, I'm glad that you anchored on that, because I think that is really important. I think communities need to feel like their community partners are truly, like you said, Ben, like trusting, right? And Jen, that they reflect themselves. I have just two things. We've talked a lot about pipeline, even both in the landscape and in the strategies, and that's wonderful. I think it does take, it's an investment, right? That takes quite a bit of time. I want to ask just really two burning questions. One is really about, there are clinicians, there are care professionals in the many ranges, but there's also environmental workers. There's all sorts of people who are parking attendants. What are we doing to control the burnout so that we're not losing them, Ben, to Starbucks? I used to actually go to places and find great people and have them be our referral clerks and everything else. I felt like I was the opposite. Like I would spend so much time in my community, in like the local, like the great, like waitress, like I need you in my ambulatory clinic, right?
Mm-hmm.
I feel like we're having the opposite effect happening now. They're all leaving and going to Starbucks, which makes really no sense. Doing to control burnout, what self-care strategies or practices are you guys seeing in sustainable ecosystems? And I think, we've been talking about community health workers and MAs and all of this for a very long time, but let's be real. Those are typically the most lower paid jobs that still are not adequate living wage for people to live. So I want us to index on what do we do about burnout today in all levels across and I'm not talking hospital specific here, but then the other thing is, how do we address the issue that Jen touched on, which is, we are not meeting level of licensure, right? And how do we right size getting clinicians doing clinician work and getting NPs doing NP work or PA work? And even if it says it in the regs and we've never done it, how do we start trying how to do it? So it's like a two-part ending of the road question here. I'm going to start with you, Jen.
Yeah, my pleasure. Well, for as far as what are we doing for resilience, we had this interesting little meeting with a lot of our frontline nursing across the entire organization. And they said, please don't talk to me about burnout, because don't call it burnout. Burnout implies I'm the problem and it's my failure and I'm not, reacting well. Why don't you talk about my mental health and my mental well-being? And so FYI, that's just a little, tidbit from the frontline nurses that we got. But I mean, it does help from my perspective that we are a faith-based organization and folks choose to work in this environment. And so we can draw a lot of energy and support, and motivation and drive from that source of belief where we can start our meetings with prayer. We can pray with each other. We can sit there and talk about, what, WWJD, what would Jesus do in this moment? So there are things that we can do that really kind of propel
So
our
appropriate on the first day of Lent, Jen. Thank you.
Got it. But in addition to that, there's a lot of the things is just the workforce environment or the employment environment, the job environment, and a lot of those things. The only thing they require is time, compassion, and a dedication to getting to know your employees, and that's what for our leadership. There's nothing you should be doing more than spending time with your associates, spending time with your team members, addressing their needs, talking about their future. How do we open up opportunities for grassroots leadership, shared governance, unit-based councils, not to just include the nurses, but the entire care team? How do we expand on our interdisciplinary rounding to include EVS, to include the nutritionist or diet aide, to include all of those folks so they have exposure to what they could possibly be working for, and then allow us to help them in those programs as we build out CNA program, MA program, diagnostic imaging, surgical tech, and RN programs. So those are all those.
Ben, take it away.
Sure. And, on our end, so much of it is how do we reallocate time and resource? So we actually see many of our physicians who are actually expanding the amount of time they spend with patients. So they were going from 15-minute visits to 30-minute visits, but focusing on those patients who they really need to see. And so their day all of a sudden becomes a lot less stressful. Some of it, when you're out of a fee-for-service role, is just making your life easier, right? Instead of ordering the same labs in every single patient, if those patients may not need those labs, all of a sudden there's less work to do to follow up on all of that. If you can manage more care within primary care, all of a sudden you need to coordinate with fewer specialists. And so hopefully, making the workload a little bit lighter. The other part is, working as a care team, right? Working with APPs, having MAs, practice at the top of their license. So I think there are a whole host of things that we can do to really rationalize the care. And then by changing the economics, you can do things that you weren't paid for before, but they just result in better care. And, that could be, whether it's a telephone consult with a family member to talk them through sort of what's happening with their loved one in dementia, whether it's doing home visits, you could really change how you're allocating your time and sort of spread out that resource and extend the capacity significantly.
All right, rapid fire ending with you, Elizabeth. Last thoughts.
Yeah, so I saw in the chat box someone popped up about Maven and using retired physicians for referrals. I love Maven. I remember working with Lisa when she first started the program, and her dad was the first retired physician. 100%, that's another example of thinking outside the box. When I look at retention with staff, I do what Jen said. I ask myself 3 questions first with the group. What are they doing that they don't need to do because no one needs to be doing it and this is archaic? What are they doing that tech could be doing that we need to think about how to improve? And what are they doing that someone else that doesn't have their certification could do? Most of the time, when you go through someone's role and you ask yourself those 3 questions, you can divide up their work pretty significantly to lessen the burden of what they have on their plate. The other thing that I try to remember, the only thing that has been proven in literature is from this physician training residency model where they do emotional peer support groups, emotional debriefing of cases. Sometimes we forget how hard it is to be a clinician or how hard it is to be in healthcare. And when you're seeing individuals, especially during COVID, that were dying or very, very sick, and you have that burden, burden and to Ben's point, I think privilege too, but the stress of, am I taking care of them? Am I helping their life? Did I make sure I did not kill them today? Which sometimes goes through your head. That you can have these emotional peer support groups where you can debrief on your cases and talk about it. And that's been modeled in physician residency programs for the last 20, 30 years. And so trying to bring that out and apply it to all areas of the workforce where we can have these peer support groups to actually connect. So, you know, I was told my first year, get a therapist and expect that you will not sleep. And that's the nature of this game. And I thought to myself, well, come on, guys, I think we can do a little bit better than that. And so I think looking to some of the things that other organizations or other professions, you know, that you're seeing are able to do to really build that peer support and that resiliency and practice while you're simultaneously looking at what is on their plate currently that may not need to be on their plate.
Well, one of the values we do have is starting on time and ending on time, and we are 2 minutes over, but I do want to say this was really great fodder and really good insight into why this needs to be disrupted and redesigned, and really utilizing kind of equitable and inclusive design principles to do that. I think all of you guys gave some incredible examples that you are spearheading and pioneering, and so we want to follow up and keep tabs with how you're doing. But I want to really thank you. I want to thank Jeff Oxendine for opening us up, giving us a landscape of what we're seeing in the ecosystem. Elizabeth, Ben, and Jen, it has been an incredible pleasure to hear not only some strategies, not only some solutions, not only some pain points, but I think a bit of not a panacea, right? But a little bit of like, it's going to take a lot of us to really redesign a system that was never really designed to actually function well to begin with. So I want to thank all of you. And I really want to thank all of you on behalf of some of the most vulnerable people in this country who really need us to listen to their voices as we redesign this system moving ahead. Thank you so much for attending today. See you soon.